Okay, so guys, today's presentation is about how to present a case in US clinical setting or US medical setting. So I'm gonna talk to you about like how to present a case while you are rotating at the program or like doing any clinic-based rotation or doing any even tele-rotation, clerkships, externships or sub-internship. This format comes handy. So I don't know about different places like different countries, but I know in India, people usually don't present case in the format of SOAP. We were not taught like this way, but in America, people want SOAP method. So let's start it. So SOAP method. So SOAP format is this. So SOAP means S stands for subjective, O for objective, A for assessment, and P for plan, and last one is disposition. So this is the format that everybody has to follow to present a case. Okay, so if a patient is coming to you, so either like if you're a medical student or if you're a sub-I or if you're a resident, you have to follow this format to present a case so that your attending can get all the information from your case presentation and you can formulate assessment and plan. So this is the SOAP format presentation. So S stands for subjective. So initially, when you encounter any, so if you encounter any patient, what should be your initial thing that you need to write or you need to present to the attending? So this is subjective. So subjective stands for all the identifying information of the patient you have to tell in the initial first line. So initial first line means like imagine there's this patient. So patient X. So she comes to the ED or to the hospital or to the clinic, and you can present in this way, like Miss X. She is a 67-year-old female, and now we don't include race, so you don't have to include the race. Earlier, we used to say that African American, Caucasian, or Hispanic, or Asian, but now new guidelines says that we do not have to include the race. It was sometimes it's really handy to include the race because like there are a lot of diseases that runs in the race, like some diseases are very common in Hispanic people, some are very common in Middle Eastern people, some are in present differently in uh, African American community. So now we do not include race. Earlier we used to, but now we don't include the race. So age, then sex, then comes the past medical history, like diabetes mellitus, hypertension, coronary artery disease, congestive heart failure, uh, chronic kidney disease. So, so these things we have to include in our subjective history taking. Then come the line that you have to mention this, that the person came to the ER with the chief complaint. So here you have to write the chief complaint. So I'll do this way. So I'll start. So I'll summarize this page like this way. So Mr. X, he is a 67-year-old male with past medical history of diabetes mellitus type 2, diagnosed in this year, and hypertension, chronic hypertension diagnosed in this year, and then coronary artery disease, status post stent placement in 2009, and then congestive heart failure with ejection fraction of 40%, with the last echocardiogram in 2017, and then CKD with baseline creatinine of 2, uh, came to the ED or came to the ER with the complaint of dizziness or altered mental status, whatever the chief complaint of the patient, you have to present in this format. So age, then sex, then past medical history with pertinent information. So if like person has CHF, then you have to mention the ejection fraction in the last echocardiogram. If the person has CKD, then you have to tell the baseline creatinine because that will give the broad picture of the patient. Like sometimes people who are ESRD patient who are coming to you, their baseline creatinine is not like 1 or below 1. It is sometimes it can be 3, it can be 4. So you have to mention baseline creatinine, and same way ejection fraction also. Then you have to describe the chief complaint in this order. So initially, the subjective part, like a patient age, sex, and then like the past medical history, Then comes this part, the chief complaint. So you have to elaborate the chief complaint. So usually there's this mnemonic OPQRST. So OPQRST means O stands for onset, P for provocation, Q quality, R radiation, S is the severity of the symptoms, and T is stands for timing. So if a person comes with chest pain, okay, so you have to present like this is a 67-year-old male or gentleman with past medical history of this, came to the ED with the chest pain. Then you have to start like when onset. So it started sudden, it was sudden in or insidious or whatever the onset, you have to mention that. So sudden onset, it was sudden onset, how it got provoked. So provocation means like how, what made it to increase, or like what decreases the pain. So it can be like sudden exertion or sudden shocking news, or sometimes people also have they drink alcohol and suddenly they develop chest pain, or sudden any sudden physical activity, or sudden sudden exertion that provocates any symptom. You have to mention that in the provocation part. So the chest pain was sudden in onset, and then it got provoked by maybe exertion or like whatever, and then the quality. So how was the pain? So the chest pain can be dull, stabbing, colicky. So colicky is abdominal, and diffuse visceral abdominal pain. So chest pain can be like it's kind of like, usually people say that like it's the quality is like somebody's squeezing inside like in the chest, and it feels like somebody's squeezing inside, and people feel like somebody's sitting on their chest. So this kind of pain, sorry, so this kind of pain is there. So quality comes, then comes the radiation. So so pain was sudden in onset and got provoked by exertion, and the quality was squeezing pain. And the radiation, so the pain was radiating into the arm, left shoulder, left arm, medial side of the arm, and also the neck and jaw. So the radiation part you have to cover, and then the severity of the symptom. So severity of the symptom, usually in the American setting, so you tell patients like on the scale of 0 to 10. So 0 being like the no pain, and 10 being like the maximum pain. So how would you rate your pain? So usually if you give this scale to the people, so they will say that like my pain is 7 out of 10, or my pain is 9 out of 10. Somebody will say like my pain is 10 out of 10. Some people will say like 11 or 12 out of 10, or infinite out of 10. So it varies according to the perception, but you'll get the brief idea. So you have to ask the severity of the symptom and then the timing. So in the severity part, you also have to ask these questions like when was it maximum, and how about the pain or the symptom right now. So they will tell you that like now after like some rest, I'm not feeling that bad, or my pain has subsided. But before, when I had this acute onset, at that time it was really like it was uh, like maximum at that time, and I would rate 10 out of 10 at that time, but now it's 7 out of 10. And then the timing. So the timing comes the last. So in which like you can describe as like how long does it last. So sometimes people have like chronic chest pains or chronic abdominal pain that comes and goes, sudden ischemia, and then it comes and then it got relieved. So this kind of thing. And then intermittent or constant. So it is like, is it like it comes and goes, or is it like constant? It happens like it's a constantly going on and on. So you have to incorporate all these things into your initial subjective HPI. So HPI, you have to include all these things. Now comes, there's this one more way, like people include pain, or like people put pain or any symptom like Socrates. So Socrates is basically in India, like people say that the site of the pain, onset, character, radiation, associated symptoms, timing, exacerbating or relieving factors, and the severity. Uh, Out of 10, how much is like the pain scale? So this is also the way that you can present. And the previous one, like OPQRST, in America, people follow OPQRST. in India, or like maybe in other part of the world, people follow Socrates. It's up to you. The mnemonic is basically both the things are same. Then comes like after doing this subjective HPI, you have to review pertinent systems. So pertinent review of system should be there. So in this particular section, focus more on the review of system where like the chief complaint is localized. Like if you have chest pain, so you should be reviewing more the chest area instead going to abdomen or head. So the chief complaint, the review of system revolves around the chief complaint area. So it can be written as like patient endorses these things, and so all those things. So you have to particularly ask. So in review of system, you have to say that general all those things that patient is mentioning. Like if the patient is mentioning nausea, vomiting, or diarrhea, or uh, burning sensation in their chest, you have to mention that like patient endorses burning sensation in their chest and also some sour taste in their mouth, and that will take our diagnosis towards uh, GERD, not towards cardiac causes of chest pain. So all these things you have to review. So you have to ask all these questions. So it comes handy when you have this list. So general review of system means like you have to ask, are you witnessing some kind of sudden weight loss? Or do you feel fatigue? Do you have night sweats? Do you have fevers or chills? Do you have sleep changes? And in the section of respiratory in the respiratory section, you have to mention that the person has cough or not, sputum, how's the sputum, color of the sputum, uh, does he have hemoptysis, like blood in sputum? If there is no blood in the sputum, you have to say no blood in the sputum. If the person has shortness of breath or not, if the person has wheezing, then comes the GI system. If like a patient has some GI pain, then you have to mention nausea, vomiting, associated diarrhea, associated constipation. If the patient has chronic constipation, you have to mention that like patient endorses chronic constipation. Then abdominal pain, where like in which quadrant he's endorsing the pain. So you have to mention that. You also have to mention like if the person has GERD or not, is he taking any medication, then bleeding, then urinary symptoms like frequency, urgency, hesitancy, pain, and blood, or like any other change in the urine. Then endocrinology, you have to mention these like patient is taught. So these review of system are basically, so if the person is coming with chest pain, then you have to mention the musculoskeletal part, and also the respiratory part, and also see cardiovascular part. If the patient is having palpitation, orthopnea, diaphoresis, and chest pain, like what kind of chest pain is there? So review of system is basically confined towards that part of the body where like patient is complaining of chief complaint. Other part you can include, but it's up to you. If those symptoms are directing you towards your diagnosis, you can include. And you also have to take the negative review of system, means like if the patient is coming with the chest pain, so you can say that like patient is not endorsing of any GERD like symptoms, no epigastric pain, or no burning sensation. So it will direct your diagnosis towards cardiac chest pain instead of diverting it towards GERD. So all these things you have to include. So weakness, dizziness, tremors, memory, ataxia, all these things. Okay. And after these pertinent review of system, so our case was like this, that Mr. X, he is a 67-year-old male with past medical history of this, came to the ED with chief complaint of sudden onset chest pain, which started when he was shoving, or like which when he was digging a hole in the ground in his backyard, and the pain was like squeezing pain. It was radiating to his arm, shoulder, arm, and jaw. And with that, all these pertinent things, with that, like you have to do the review of system. So review of system, patient is not endorsing any nausea or vomiting, but patient is endorsing of palpitation, uh, diaphoresis, and shortness of breath, but he's not endorsing any burning sensation or epigastric pain in his chest, and not and also not endorsing any any sudden loss of consciousness or weakness or dizziness or tremors, or all these uh, all these review of system you have to mention, some negative, some positive, so that we can reach to our diagnosis by even listening to the HPI part. Okay. And after that comes the pertinent history of medical history, social history, and family history. So you have to mention that in the subjective part, that medical history. So medical history means like any chronic disease or history that is with, like, so you can say that like if the person has hyperlipidemia or hypertension since starting, or like since 2017, and then which medication he's taking for all those problems, any surgical history in with the timeline. So if the person is like some people have pheochromocytoma, and you remove that pheochromocytoma, but suddenly it reoccurs, and then suddenly it develops, like patient can develop palpitation, sudden headache, shortness of breath. So all these things you have to mention. The surgical history you have to mention. Depression and mental health, you have to mention like a patient has depression or any mental health issue, and what kind of medication are they taking, and the herbal supplement, if they're taking any medicine or like any supplement they are taking, you have to mention, because like sometimes they are associated with these common presentation. So medical history, and then comes the social history. So in social history you have to mention like where like the place where patient lives, and who is living with the person, and where does that person work, what kind of diet he takes, is he regular, is he like an active person or sedentary lifestyle, is he is he alcohol addict or drug addict, and does he smoke or use tobacco. And you also have to ask the sexual history, sexual part also, and obstetric history, if the obstetric is for female only, and sexual like or does he use protection, or or like does he have multiple sexual partners, all these things you have to mention. And then the psych history, does he take any medication, or has he had like in the past, if he has any psych complaint, you have to mention in that part. Then comes the family history. So in family history, you have to mention that any genetic disease that runs in the family, you have to ask like, so the best way is to ask the person that like, do you know any disease that runs in your family? So they'll say like these kind of things, like cancers run in the family, sometimes autoimmune diseases run in the family, sometimes kidney diseases, like they'll say that my mom had kidney problem, my sister had kidney problem, she passed away last year. And sometimes people say that like my grandfather passed away because he had some cardiac issues, and then my brother also, he has cardiac issues. So all these things you have to ask. Then comes the family, the core family, like so you have to ask the mother, so like does she have any medical problem right now, or is she alive, or is she dead? All these things you have to ask, like mother is alive but she has CKD, father is alive, he has hypertension, siblings, they are alive, they don't have any problem, relatives, like if they have colon cancer, you can include that. So all these things you have to include in the pertinent history part. So till now it is subjective part. And also this part is also included. You have to ask the allergies, like if the person is allergic to something. So back in India, people used to forget about asking the allergies because it's not very common in India. But here in America, it is pretty much common. Like everyone is like, I've seen 90% people are allergic to something. Some are allergic to penicillin, some are allergic to some kind of other medicine, some are allergic to NSAIDs, some are allergic to uh, food, or some kind of like, some are allergic to some kind of fishes, shellfish, some are allergic to peanuts, some are allergic to insect or bee bite, some are allergic to different kind of chemicals or metals. So all these things you have to ask. So they know that like they are allergic to these things, because these people are aware about their allergies, and they'll tell you like, I'm allergic to sulfonamides, I'm allergic to uh, uh, furosemide, or some like this way they'll tell you. And sometimes you can look and in their chart also, like previous history. If they have previous history, they can, from there you can get the allergy uh, allergy history you can take out from there. After allergy, our subjective part is, now we have completed our subjective part. Now comes the objective part. Excuse me. So in objective part, now comes the real deal. So, like before this, we were doing subjective things. Now comes the objective part. So when the person came to the ED, what ED doctors did, or like what the EMS did, or all those events that happened in the medical facility, you have to include that into objective part. So I'll start with objective. So initially, so all these things like you have mentioned that like patient's age, sex, and then or the chief complaint, the past medical history, then chief complaint, and then the OPQRST presentation of chief complaint, and then the pertinent history like medical history, then social history, then family history, then allergies. Now comes the objective. So now you will say the patient came to the ED, and in during the ED evaluation, the patient's blood pressure was this, it was high, his heart rate was 110, oxygen saturation was 92% on room air, and the respiratory rate was like this. There was, so oxygen delivery method, if the patient is intubated, you have to mention that like patient got intubated during the ED evaluation, or like if the patient is breathing by nasal cannula, you have to mention that. And then temperature. So like if the patient has nasal cannula or CPAP, you have to mention that patient is on a 2 liter oxygen by nasal cannula, and the oxygen saturation after oxygenation or like additional oxygen supply, patient is maintaining at 97 or 98%. Room air, he was maintaining 85 or 86, now he's maintaining 98. So all these things you have to mention. Then temperature, and then physical examination finding, like patient was complaining of chest pain, there's no gross deformity. And then you can include the pertinent lab value. So in America, what we see is that like when the patient comes to the ED doctor sees the patient and he takes the vitals. So vitals are here. So all these vitals, and he'll send all the pertinent labs. So patient coming with chest pain, you can send like troponins. You have to send troponin, CBC, CMP, and also you have to order EKG. So EKG is the first thing you have to order EKG, and with that, all the labs. So if EKG is showing any kind of ST elevation and the troponins they come late, but EKG is showing any changes, sudden changes, then uh, the ED doctor will take care of chest pain, and they will give the loading dose of aspirin, clopidogrel, and nitrates if they are required. So all these pertinent labs like anything's hyponatremia, hyperkalemia, you see all those things. You don't have to include everything, only the pertinent information you have to mention in that. And then comes the pertinent imaging. So ED doctor will say that like he wants to do CT angiogram, or like CT scan of without contrast. He wants to do CT of abdomen and pelvis, or he wants to do chest X-ray or ultrasound. So you have to mention the finding of CT scan or ultrasound, any radiology imaging done in the ED. You have to mention that also. And then the intervention that ED doctor did or ED care team did. So if the patient came with came with hyperkalemia, so the treatment of hyperkalemia in emergency setting is you have to give the person insulin, and if the person's glucose is low, then also dextrose, and some potassium binders by mouth if he can take or she can take, and short acting beta agonist also SABAs. So all these things, and calcium gluconate to prevent heart from bad effect of hypotension level. So what ED doctor did, you have to mention, and then after those interventions, repeat vitals and lab values. So the ED doctor will do the repeat vitals and the repeat values, and you have to mention that like after giving insulin and dextrose, the patient's potassium, which was 6.6, came down to 5.2. So you have to mention that. And then after the first intervention, patient's condition. So patient, if the patient was complaining of chest pain and then you gave nitrates, aspirin, and clopidogrel, the pain relieved, and the morphine, the pain relieved. Now patient is still feeling chest pain, but it is 3 out of 10. Earlier it was 9 out of 10. And then you also have to mention that the assessment of the ED doctor and the plan for admission. So you can see that, like, doctor, in the ED doctor, he took care of chest pain, and in his assessment, like, he saw that ST segment elevation, and also high troponin on serially, like if you trend troponins, it's high. So he'll say that we have N, not N, segment elevation MI, and I want to admit this patient for the further evaluation and management. Okay, so this part is objective. So you have to touch, like, all these 7 headings. Now comes the physical examination part. So after that, the physical examination. So now your job starts, like what you see physically. So first, patient had chest pain. He called the EMS. EMS took to the hospital. In hospital, the emergency doctors saw that ST elevation and the troponins were high. He gave the medication, and now the patient is stable. Now you go and see, as a doctor, you see, and then you do the physical examination. So you will start from head and neck to toe. So first, head means, like, how was normocephalic, any trauma, ear, nose, then any deformity on nose, then neck, any jugular venous distension on the right side. If you see any JVD, you have to mention people with CHF present with JVD. Then carotid bruit, like if they have any atherosclerosis in carotid, you have to mention that, like, right-sided or left-sided or both. And then thyromegaly, if thyroid is like enlarged, or if there's any lymph node that is enlarged in the neck region, you have to mention. Then also sometimes you have to mention that patient's mucous membranes were moist or dry. If the patient is dehydrated, obviously it will be dry. And if the mucous membranes are moist, that means, like, person is not dehydrated. Okay, then comes the eyes. So sometimes extraocular movement in stroke patient, you have to see the extraocular movement is intact or not. Sometimes you also have to see conjunctiva and sclera. So sclera is important if the patient is hepatic cirrhosis is there, or any jaundice, you have to see the sclera. And conjunctiva can be like so in, like, if the patient has any kind of intoxication like phencyclidine or marijuana, their conjunctiva is injected or red. And then you also have to assess pupil. So pupil are equal or not, round, or then reactive to light or not, so that you can evaluate, like, the brain situation. Then comes the cardiovascular part. So cardiovascular part is, so you have to see the rate and rhythm. So a lot of people come with AFib, and in which, like, you see that their heart beats like it's like very irregular. So AFib patient, you have to check the rate, like, is it regular or irregular, and is it tachycardic or bradycardic. So, and then the pulse, you have to assess the pulse. So is it like normal pulse in both upper extremity and lower extremity, or is there pulse deficit? So you have to mention that. And then comes the heart sound. So heart sound can be normal heart sound, S1 and S2, like dip 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 dip, but it can be irregular, or like different. Sometimes you can hear S1, S2, and S3. Sometimes you can hear the murmur. Sometimes you can also hear rubs. Sometimes you can also hear gallops. So there are a lot of things that you have to look while auscultating heart. Then cardiovascular, then pulmonary. So pulmonary, you have to see that if the person is breathing properly, bilateral air entry is present or not, and also if the person is putting a lot of effort, or like using accessory respiratory muscles, like this way, then you can say patient is not able to breathe by normal diaphragmatic breathing is not present. Person is using accessory muscles. And you also have to comment on breathing sound, normal vesicular breathing, bronchial breathing. Uh, do you hear any rhonchi, wheezes, or crackle? And which segment of lung? So you have to auscultate like anterior segments, posterior segments, basal, apical. So all these things you have to comment, like any irregular or away from ordinary, you have to mention. Then abdominal examination. So we did head and neck, and then chest, means like cardiovascular, pulmonary, and then comes the abdominal. So abdominal is, so you have to mention that abdomen is flat, it's not tense. Like in patient with ascites, they have tense abdomen, that is protruding abdomen. And you also have to comment on bowel sounds, and then palpation, like abdomen is soft on palpation or not, like, or is it tender, is there any guarding present, is there any kind of sign, Murphy sign, or any other thing that is present, or you can elicit fluid thrill. And sometimes you also feel resonance, like sometimes people have ileus, and in that case, like their abdomen is distended without any bowel sounds. So you have to comment on that. Then comes the musculoskeletal. So musculoskeletal means like any weakness, normal range of motion, power, tone, reflexes. So you have to mention all these things. Then comes the skin. So skin means like if the person has warm and dry skin, or is it like uh, does he have any kind of lesion on the skin? And in patient with dehydration, you or like hypovolemia, you see that like capillary refill is less. Usually it's less than 2 seconds, but it can like prolong to 3 or 4 seconds. So that actually will give you the clue of the hydration status or volume status. Then neurological examination, like if the patient is alert, oriented to time, place, and person. Time means like he can tell you the present date and also the time. Place, so you can usually ask like, can you tell me where you are right now? And if the patient says like, I am at my home, that means like he's not oriented to place. So uh, and then comes the person. So you can ask like, who's the president of America right now? So if he says George W. Bush, that means like he's not oriented. Okay. So then you also do the general neurological examination, means like if there is any focal deficit present, like if the patient is not able to hand, like lift his hand, or if there is any cranial nerve problem is present, means like any drooping of face, or saliva is coming out, or Bell's palsy like symptoms, you have to mention. Uh, all the cranial nerve examination. If the patient comes with stroke, you have to do cranial nerve examination. And then you also have to comment on mental status, because if the patient is oriented to person, place, person, and time, but if that person is at baseline, you have to mention that this is the baseline. And sometimes people are like old people, they have memory problem, or they are constantly in a delirious state. Their baseline can like go up or down. So you can comment on that, like patient's baseline is that like he's not oriented to time and place, but person he's oriented, that was his baseline, but now he is like disoriented to everything. Then comes the psychiatric, means like mood of the patient, behavior, thoughts, and judgment. All these things you have to ask. Like if you're good with psych examination, you can write that. And then if you have any other pertinent organ that you want to comment on, you can use here uh, in the physical examination part. Like sometimes sensory examination, sometimes genitourinary tract, you can mention that here. Then comes the assessment and plan. So we started from the patient who was coming with chest pain with a lot of chronic medical problems. Then in the ED patient, EKG was showing ST elevation, troponins were high, and then ED doctor gave him aspirin, clopidogrel, and then some nitrates and morphine. And then in your assessment, what is so that was ED's assessment. Like you did your physical examination, you review the chart, and you saw all those lab values and vitals and radiology imaging and EKG. Now, what is your assessment, and how, like, what is your plan? So while presenting, you can say this way: after physical examination, your assessment and plan comes combined. So you can say that the you can summarize the patient in one sentence, like patient is 64-year-old male with past medical history of this came with the chief complaint of chest pain. During the ED evaluation, uh, the diagnosis or it was showing the ST elevation or these things. And in my assessment, this patient has CKD or ST elevation MI, and the lab values are pertinent, like showing this. The deranged lab values you have to mention, and then all these things that take you towards the diagnosis you have to mention, and then the plan. So you can say that like my plan is that like I'll start the patient on some kind of anticoagulant, means like heparin drip or something, or Lovinox or some kind, and then send to the PCI lab or cath lab to assess the blockage and put the stent. So in that ST elevation MI, you can say this way. If the patient has CKD, so in CKD, you have to mention that the lab values of creatinine and the GFR. So GFR, if GFR is less than 15, that means the patient has ESRD. And you have to mention that like baseline creatinine is like where, so patient's baseline creatinine was this, ESRD patient on hemodialysis or peritoneal dialysis, and the diagnostic criteria for staging. So if the patient's GFR is 30 or like 25, then which stage of CKD the patient is, you have to mention that. And then you have to mention the like after assessment, the plan for treatment. So if the patient has CKD, in that case, like you have to avoid nephrotoxic drugs. You have to give IV fluid to prevent pre-renal azotemia, and also manage blood pressure and diabetes. All these things you have to manage to preserve the function of the kidney. And then first assessment is the first assessment is the chief complaint, and then comes the other problems. Like if the patient has diabetes mellitus, then you also have to comment on HbA1c, and then the nephropathy, neuropathy, retinopathy, and if the patient is compliant on medicine or not, and the present medicine, if he's taking anything or not, and then your plan, like how do you want to address this problem. So diabetes, if the patient is compliant and able to manage, then that means like you can so you can say that like that patient was compliant on the medicine, and we would continue the present home medicines. Otherwise, like if the patient's HbA1c is over the roof, then you have to start the insulin. So you'll say that I'm starting insulin. Then address the other past medical history or the present history, like the hypertension or any other medical condition that patient is taking medicine for. So if the patient has hypertension, then you have to mention like the present blood pressure is that, and patient was taking this medicine, and now we want to start these medicine because of this reason. So every assessment should have the diagnostic criteria, like what made you assess, or like what made you to come to this conclusion, and also the plan, like how you want to address this assessment, like how you want to treat the present condition. Every assessment should be like this, and this. Okay. And then comes the differential diagnosis. So after the assessment comes the differential diagnosis. So you have to give them like, so differential diagnosis is not that important, but like doctors will ask, like, what is your differential diagnosis? So if the person is coming with chest pain, the differential diagnosis can be GERD. Sometimes pulmonary embolism can cause chest pain. Sometimes costochondritis can cause chest pain. So they'll ask you like how you are ruling out these differential diagnoses. So for costochondritis, if you elicit, like if you press on the chest, the person will say like, I feel pain. And usually people, young age people who go to gym, like usually they feel costochondritis happens to them. And also then GERD, if the patient says like I have chronic history of GERD, and also like I take Protonics, means like pantoprazole at home, but I forgot to take it for 2 or 3 days, and now I'm feeling this burning sensation. Then differential diagnosis can this be like the patient is complaining this, and he's not complaining chest pain on exertion. So the differential diagnosis is, so you can rule out the cardiac cause, you can rule in the GI cause, or like esophageal cause. In this example, like if the patient comes with right upper abdominal pain radiating to right side of the chest and neck, I think this is likely a cholecystitis. So the right side hypochondric pain that is radiating to right side till the neck. Sometimes it can be cholecystitis, but you have to rule out with the CT abdominal ultrasound findings. So usually people do CT scans in the ED, and you can rule out on the basis of CT scan or abdominal ultrasound. Acute coronary syndrome. So if the patient's EKG is normal and the serial troponins are normal, you can rule out the ACS. Pulmonary embolism, you can rule out by checking D dimer and CT angiography. So if the D dimer is negative and the patient is able to breathe properly and the CT angiogram is negative, then you can rule out pulmonary embolism. And if the costochondritis, so basically costochondritis is diagnosis of exclusion. And if you palpate the area where the patient is feeling pain, you can elicit like pain when you press it, or like sometimes people also complain that only on breathing they feel pain, but when they stop breathing they don't feel pain. So in that case, like costochondritis can be ruled in. After that, assessment and plan. Your admission, if the patient is getting admitted, or and the management is like you also have to put admission and management, that you have to do in these following headings. So after assessment, then plan, assessment plan, and then the differential diagnosis, then comes the admission and management. So first we have to take care of three things. One is the fluid. So if the person is dehydrated, like which fluid do you want to start? Like, is this normal saline, ringal lactate, and D5W, or DNS, or half normal saline with DNS, half normal saline with D5W, or like whatever you choose the fluid, and how do you want to give the bolus? So sometimes bolus can be like 1 liter over 2 hours, and sometimes bolus can be 2 liters over 1 hour, and then the maintenance fluid. So usually maintenance fluid, the rule is 4 to 1. So 4 to 1 rule we have to follow for the fluid maintenance. Then comes the diet. So if you're admitting the patient, the diet is also the important part. So which kind, which diet do you want to give to the patient? So before giving the diet, you should do one thing. You should evaluate patient for swallowing. Like if the patient is able to swallow food or not. If they are not, then you can probably cause aspiration or more damage than benefit. So usually before, so it is pretty much important for stroke patient. If you see any stroke patient, you have to evaluate the swallowing, or like altered mental status patient. You cannot just give the normal regular diet or cardiac diet or renal diet. You cannot. So if they are able to swallow properly, then only give diet. Otherwise, NPO. Some people you can give normal regular diet, then renal diet for ESRD patient or CKD patients, cardiac diet for all those people who have chest pain because of cardiac reason. Then low calorie diet, sometimes high calorie diet also, soft diet all to all those people who cannot chew properly, liquid or clear diet for all those people who are being shifted from NPO. You can start the liquid diet if they can tolerate. Sometimes we also have to write NPO. So NPO means nail per oral. So they are not taking anything except medicine or without any exception. So all those patients who are going for some kind of procedure or who have poor swallow reflex, or they are not able to swallow, then we have to put them on NPO. And this is very important, DVT precaution. So for every patient, you have to write fluid, diet, and DVT precaution. So DVT precaution is for like patient stays in hospital. If they are not able to walk, or they are not mobile, there are chances of developing blood clots in their lower extremity. So we have to give DVT prophylaxis. So usually, if the patient is not very prone for DVT, then we usually do this compression devices like pneumatic compression devices or stocking. We give compression stocking. Sometimes we give heparin drips to people. Sometimes we give Lovinox subcutaneous 5,000 units per day. Sometimes people are on Eliquis or Apixaban, then we continue that medicine. So at that time, we don't need to give the DVT precaution. So all these things are there. Okay. And after that is reconciling the home medication. So if the person, so just I'm just giving you the picture from the starting to the end. So usually when you present the case, you don't have to mention the medication reconciliation, because you have already mentioned that in your HPI, that the patient was taking these medicine, the dose was like this, and he was taking on these days. So, but if you are admitting the patient, then at the time you have to reconcile the home medication. Okay, so what are the home medication that you have to reconcile? So if the patient is like, if you want to continue some certain medication, like if you want to continue aspirin, if you want to continue levothyroxine, because these medicine you have to continue, and also the blood clot, like blood thinners, Eliquis, you have to continue that. Some medication you can put on hold, like if the person is coming with altered mental status and you don't want to give uh, some benzodiazepines, so put that on hold. Okay, some medicine you have to discontinue. So like if the patient is coming with toxicity of some medicine, you have to discontinue, or like if you see any side effect, you discontinue that medicine. So all these comes the home medication reconciliation. Then comes the disposition part. So after doing everything, where do you want the patient to go? So you saw in the ED, now you have presented that case to the doctor. Now doctor will ask, how do you want to do the disposition? So if the patient is in the ED, and over there, if you want to manage the critical condition, you can say like, I want to hold the patient in ED before taking to the general medical floor. Sometimes you can say that I want to take the patient to general medical floor because the condition has improved and now we just want to observe the patient. Sometimes you can directly transfer to CCU, cardiac. So you can transfer the patient to CCU. And sometimes they want ICU care, like their respiratory system is not good. They want, like you want to intubate, or like they got intubated in the ER, and now you want to shift them to ICU. Sometimes people with chest pain, you directly transfer them to ICU, cardiac cath. So you can transfer to cardiac cath lab. And also, if if you want to transfer, sometimes your hospital is not equipped enough, you can transfer the patient. Sometimes you can discharge also from the ED, so it depends on the situation. So disposition part is this. Then this is the small presentation that I actually wrote. So you can say that a 5-year-old male, or like a boy with past medical history, with no past medical history, is brought to the emergency department by his mother for vomiting and diarrhea. This is our chief complaint. Okay, his mother says, so as per his mother, he started complaining of stomach pain after playing at the neighbor's farm. But I thought he was just hungry after playing outside all afternoon. The child subsequently had several episodes of emesis and diarrhea. His mother has also noticed that he seems to be sweating excessively and drooling. He has no other medical condition and takes no daily medication. So medical part, and the is now they have covered medical part. The patient lives with his home. So this is the social history part with parents and uncle. His uncle has sickle cell disease. This is the family part, for which he takes ibuprofen and oxycodone as needed for the pain crisis. Then comes the ED evaluation. So we have completed the history HPI part till now. And then comes the observation part of, like in the ED observation, the temperature was 99°F, blood pressure was 90 by 60 millimeter of mercury, pulse was 15 per minute, respiration was 36 per minute, pulse oximetry showed 94% on room air. So now ED evaluation, the vitals we have completed, and the physical examination. So ED physical examination shows an ill-appearing child moaning on the stretcher and clutching his abdomen. So, and he also has significant diaparesis and bilateral tearing are noted, and his pupil are constricted. So these are the pertinent review of system. So all these things were written. The cardiac examination reveals a regular rhythm with bradycardia and no murmur. The respiratory exam is stable for tachypnea, bilateral wheezing, and mild subcostal retraction. Oxygen by face mask is administered. ED gave him atropine in suspicion of organophosphate poisoning. So do you see like how this presentation is done, in which like this presentation touches everything, whichever like headlines I talk, it has touched everything. Now you know the brief picture that the patient, the boy, the 5-year-old boy, might have drank or like accidentally drank some organophosphate, and now he's having all those symptoms of OP poisoning. So now you can address this presentation by assessment, like in my opinion this is OP poisoning, because the like lacrimal drooling and all these symptoms and the temperature and diaphoresis and constricted pupil and wheezing, bilateral wheezing, subcortical retraction. So all these things point toward OP poisoning. So you can put that, and then the plan can be the atropine, and then like PAM. So all these things comes later. Okay. And then where do you want to dispose this patient? Or like what are your, so before disposition comes the differential diagnosis of why not other things. And then why you want, like why do you want to take this patient to ICU, or like why do you want to take this patient to general medical floor? All these things you have to mention. So this is the way you have to present the case. Okay. So this was the presentation. I hope you guys learned from it and enjoyed it. And if you guys have any question,